Good afternoon, everybody. Hi, thank you so much for joining us today. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. And on behalf of our staff and board of directors, thank you all for coming to today's briefing on the role of the healthcare workforce in delivery system reform. For those who are not familiar with the Alliance, we are a nonpartisan organization that's dedicated to advancing knowledge and understanding of health policy issues. And we want to invite you, if you want to tweet at today's briefing, at #FutureOfHealthcare to go ahead and do so. A couple words about this briefing. It's the final briefing in what has been a three-part series on the healthcare workforce. And it's the final briefing in a year-long program that we've done on the future of healthcare, both in conjunction with our 25th anniversary as an organization and wanting to look at some of the broader issues that are important to our healthcare system beyond the day-to-day that we may all focus on. So we're really thrilled to be here. And I want to thank the sponsors of the year-long series, Anthem, Ascension, and Health is Primary, for their support throughout the year, as well as those who have supported the Workforce Summit series, the AAMC, the American Association of Medical Colleges, Leading Age, and the Elder Care Workforce Alliance for their support. So thank you very much. I'm going to briefly turn the mic over to Elizabeth Hall, Vice President of Federal Affairs at Anthem, for a couple of opening remarks.
Thank you so much, Sarah. On behalf of Anthem, we are really excited to be partnered with the Alliance and their other sponsors on the Future of Health series. The future is very exciting, and on behalf of our 53,000 employees and over 3,000 clinician employees, we know that it is the people who really put care in healthcare. And as I said, it's really a very, very exciting time, and we're really interested to hear the insights that the panelists have to offer today, because we are taking those insights and we are applying them faster and more effectively than we ever have been able to before. And I'm just going to note one thing that we are working on at Anthem through our CareMore subsidiary is that we have challenged every member of our team to help us address social isolation amongst seniors. We are just about 6 months into this project. We have amazing anecdotal results from that project, and we can't wait to share with everyone the clinical outcomes that we have found. But that takes our clinicians, but as well every part of our workforce. So again, we're very excited to hear the insights today and to be able to take those and apply them. Thank you.
Great. Thanks so much, Liz. Next, I'll turn the mic over to Kirsten Thistle, representing the Health is Primary campaign.
Thanks, Sarah. Again, I'm Kirsten Thistle. I'm the campaign director of Health is Primary. And I know Sarah's probably sick of hearing me ask this, but how many people have heard of the Health is Primary campaign? All right, it gets better every time. Health is Primary, for those of you who don't know, is a collaboration of the 8 family medicine organizations in the U.S. Our goal really is to showcase the value of primary care and highlight the tremendous innovation and transformation that's happening in delivery system. I just want to give a shout out. I don't know if Liz just left, but we have been featuring a lot of the work that CareMore, the Anthem subsidiary, has been doing just in terms of integration. It's really great work. Some of their case studies are featured on our website. It is pretty extraordinary when you look at the value of primary care. We have data that shows that for every dollar spent in primary care, there are $13 saved in downstream costs, which is a pretty extraordinary ROI. But we certainly can't do it without a strong primary care workforce. I know probably everyone's aware that there are issues on primary care shortage, so certainly important that we're talking about this today, and hard to believe that we're at the end of this journey with the series, but I think lots more to do next year. Never a dull moment in healthcare. So thanks again, Sarah, to your team, and to the Alliance for putting this event together.
All right, well, thank you again. So again, you've heard a little bit of background of why we're doing this briefing, but for those who maybe have been following the Alliance's work over the last even couple of months, we've done several briefings around delivery system reform, and we often talk about delivery system reform and value-based care in sort of one bucket, and workforce Supply, demand, shortages, team-based care kind of in another bucket. And so part of the purpose of today's briefing is really to try to bring those two topics together and talk about the people who are in fact delivering on the delivery system reform and what that means for them and what delivery system reform means for improving both the way that care is delivered and the impact on the workforce and what kind of workforce that we need to achieve a high-performance healthcare system. So we have a really excellent panel today to help us explore these issues, and I'm going to go ahead and introduce them before they give their presentations and we get into a Q&A. So to my right, to your left, is Tim Dall. Tim is Managing Director for HIS Life Sciences Consulting and has more than 20 years of experience conducting research and policy analysis in the areas of health economics, health workforce, healthcare delivery, and disease cost and prevention. Tim earned his Master of Science in Labor Economics from the University of Wisconsin-Madison and his Bachelor of Science in Economics from Utah State University. Next, we'll hear from Bob Phillips, who is Vice President for Research and Policy for the American Board of Family Medicine. He's also a part-time practicing physician in a community-based residency program in Fairfax, Virginia, and a professor of family medicine at Georgetown University and Virginia Commonwealth University. He obtained his medical degree from University of Florida College of Medicine, Master of Science in Public Health from University of Missouri, Columbia School of Medicine, and his bachelor's from the Missouri University of Science and Technology. Welcome. Next, we'll hear from Cheryl Phillips. Cheryl is President and CEO of the Special Needs Plans, or SNP Alliance, a national leadership association for special needs and Medicare/Medicaid plans serving vulnerable adults. Prior to this, Cheryl served as Senior Vice President for Public Policy and Health Services at Leading Age. She obtained her medical degree from Loma Linda University School of Medicine and bachelor's degree from University of the Pacific. Welcome. Next, finally, we'll hear from Blair Childs, who is Senior Vice President of Public Affairs for Premier Inc. Blair is the primary spokesperson and communication strategist for Premier on key issues impacting healthcare cost and quality, and previously was Executive Vice President of Strategic Planning and Implementation for AdvaMed, the Advanced Medical Technology Association. And Blair holds a bachelor's degree in history from Middlebury College. So welcome to all of you. We're excited for today's discussion, and I'm going to go ahead and turn it over to Tim Dall to kick things off. Thanks.
Great. Thank you for the introduction. So the work that I do is a lot of work for the federal government, for state governments, and various associations and other entities on modeling the health workforce. And to get started, I'll just briefly describe how we do the modeling and then talk about what some of our findings are. So the purpose, of course, is modeling is to make sure we're training the right number and mix of health professionals to meet the demand for services. I'm going to be talking just about at the national level, but recognizing that across the U.S. there is a substantial geographic variation in adequacy of supply, but I'll focus on the national level for today. In terms of workforce supply modeling, it's fairly straightforward. You start with the current workforce. You model how many people are retiring. You model how many new people are entering and how many will be there the next year, and then you keep simulating this over time. And even though it's fairly straightforward, as you might imagine, there's always data issues that you're encountering, and unknowns such as are there shifts in trends in retirement and hours worked patterns, but taking into account the changing demographics of the health workforce and what the supply will be in the future. On the demand side, it's a little more complicated, and the way we do it is we first need to model what are the characteristics of the population both now and into the future. So what we do is we use mostly national data sources, some state data sources, and create a representative sample of the population. And for each person, we know things like their demographics, the presence of disease like diabetes, heart disease, lifestyle choices like do they smoke, are they obese, information about their household income and insurance. And we know this and project it out into the future. Then what we do is we look at current patterns of healthcare use and staffing to develop a baseline or status quo scenario, which is if we don't change how care is used and delivered, what will be the demand for providers out into the future? And then that allows us to do those what-if scenarios. What if we change the way that people use healthcare services or how it's delivered, and what would be the implications for the health workforce? This graph right here shows some different scenarios on the demand side that we did for physicians. There's a lot of lines there. Basically, the solid lines are the demand projections, and the dotted lines are the supply projections. And the main point to take away here is that under the various scenarios that we model, in most cases, the demand for physicians outweighs or is above the supply. And that leads us to believe that as we go out over time, that we have a growing shortfall of physicians. And this is at the national level. And if you have a growing shortfall at the national level, it will tend to exacerbate problems at the local level, especially for those areas that are already having challenges recruiting and retaining providers. When we look at the nurse supply, this is work done for HRSA, we get the exact opposite. A decade ago, we were training about 75,000 nurses a year. Now we're training close to 160,000 a year, and we seem to have overshot the mark. Whereas a decade ago, we said we'd be short 1 million nurses by 2020. Now we're projecting that we're training too many. So as we think about what exactly does it mean to model a high-performing healthcare system, there are a number of organizations that have helped to define what exactly that means. And it boils down to a handful of things. Coordinating care across delivery settings and across provider types, targeting a high-risk population and managing their chronic disease, meeting various population health goals, and improving the efficiency with which we provide care. And you can kind of break this down into two major categories. One is those clinical things that affect people's health, and then more of the behavioral things or the staffing that affects people's use of healthcare services or how the care is delivered. I'm going to present some results from our clinical modeling, and the part on healthcare use and delivery patterns. It's an ongoing process that we hope to have some results within the next month, and it should be published in the spring. So what we then, let me go back a slide here. What we modeled on the clinical side was some achievable outcomes. If we can get people who are overweight and obese to lose 5% body weight, the recommendation is 10%, but if we can get them to lose 5%, if we could get people to better manage their blood pressure, their cholesterol, their blood glucose levels, along lines that we have seen in the published literature, if we can get 25% of the people to stop smoking, which is an achievable goal, although there's a high attrition rate in terms of a recidivism rate. And what we're still working on is if we can divert people out of hospitals and emergency departments back into the community and other things that will keep them, change how they use the care. So if we were to meet those population goals that were very manageable that I mentioned, what happens is everybody gets a little bit healthier, but people live longer. That's a good thing. But by 2030, if we had met these goals within the past year or so, by 2030 we modeled that there would be an additional 6.3 million people alive. These are mostly elderly people. Most of them are age 75 or over, and most of them have chronic conditions, but they're better managing them. So what does that mean for the health workforce? In the short term for physicians, what it means is that you might get by with fewer physicians because everyone's a little healthier and they're not using the services. But over time, as the population grows faster than what the Census Bureau projects, because people are living longer, you need more providers, such that by 2030, we estimate or we calculate that if we can live a healthier life, we actually need more doctors in the future by about 15 to 16,000. Percentage-wise, it's not a whole lot compared to an estimated 950,000 or so physicians that we might need at that time, but it means more. Similar with the nurses, we model that if we were to meet these kind of goals by 2030, we'd need about an additional 100,000 registered nurses beyond what we would need if we didn't meet these kind of goals. Okay. So the conclusions. People think that by changing the way we deliver care, we can save money, we can reduce the demands on the healthcare system. And there's a lot of truth to that, especially in the short term. But what we estimate is that in the long term, you would actually need a larger workforce because the truth is, if you can keep people alive, they need more healthcare services than people that are dead. And so sometimes people, when they've looked at some of our workforce projections, and they say, you're overestimating the demand because everybody's going to be healthier as we transform the healthcare system. And that really only works in the short term. What we find is in the long term, under this scenario, you actually would need fewer of certain types of specialties. For example, endocrinologists. we could reduce the demand for endocrinologists by about 10%. For physicians like cardiologists, you might not have too much of an increase in demand because everybody's healthier, but they're living longer. For other things like geriatric medicine, you might need to increase demand might increase by about 10% relative to what you would need otherwise because people are living longer. So I think those are the main takeaways, is that healthcare reform and ways of better managing care is good. Extending life is good. Having people live healthier is good, but it doesn't necessarily mean we need fewer doctors and nurses and other health professionals in the long term. Thanks.
Thank you. Go ahead, Bob.
Thank you. So I'm going to talk about this question about whether training meets practice and practice meets training. And I want to start with Kirsten introduced Health is Primary and the fact that 8 family medicine organizations across the country have come together to lay out both a communication and a strategic plan. And at the start of that 5 years ago, they asked a group of us to develop a 100-word definition, a role definition of what a family physician should be in order to really work in a reformed health system. And so I want to start with something we developed in the course of that we called the FOIL definition. It's kind of holding a mirror up to the profession to say what they're doing now. But before I do that, just to lay out what I'm going to talk about, I'm going to talk about what robust primary care is and why it matters to a reformed health system, asking the question of whether the market knows the value of robust primary care and is ready for a prepared workforce, and then finally, some evidence about the fact that we train physicians to do robust primary care, and we need to let them do it. So the FOIL definition starts like this, that the role of the U.S. family physician is to provide episodic outpatient care in 15-minute blocks with coincidental continuity and reducing scope of care. The family physician surrenders care coordination to care management functions that are divorced from their practices, and they work in small, ill-defined teams whose members have little training and few in-depth relationships with the physician and patients. The family physician serves as the agent of a larger system whose role is to feed patients to subspecialty services and hospital beds. And the family physician is not responsible for patient panel management, community health, or collaboration with public health. And I've done this talk across the country with this FOIL definition, and I hear gasps, I hear chuckles, because a lot of family docs come up to me afterwards and say, that is exactly what I do. That's what my health system, my employer in particular, expects from me. And that's not what the reformed health system needs. In fact, Farzad Mostashari, the former director of the Office of National Coordinator of Health Information Technology, last year published a paper summarizing some of the evidence around robust primary care and what it can accomplish. And he said recent evidence suggests that small physician-owned practices, while providing a greater level of personalization and responsiveness to patient needs, also have lower average cost per patient, fewer preventable hospitalizations, and lowered readmission rates than do larger, even independent, and hospital-owned practices. And yet, we're driving increasingly primary care physicians into these larger and hospital-owned practices. Interestingly, the Quality Payment Program seems to be doing that quite a bit because these small practices are incredibly fearful of surviving in a value-based payment model, largely because they can't report their data, not because they can't deliver better outcomes. In terms of robust primary care, it's usually characterized as delivering comprehensive, high continuity, strong care coordination, and first contact care. And so that's a definition developed by Barbara Starfield and studied by her over the years, and we've tried to now translate some of those 4 C's into measures. And so we actually published a paper in 2015 around comprehensive care with the Robert Graham Center, and we were able to demonstrate as care comprehensiveness increases, hospitalizations go down and expenses go down. And not just Part B Medicare expenses, which are the payments to the physicians, but Part A, the hospital-based costs go down. And we have a paper under review right now showing that as you increase continuity, as you deepen the relationships between providers and patients, that costs go down as well. In fact, we demonstrated a 15% reduction in costs, 35% reduction in hospitalizations with high comprehensive care. And we have another paper coming out demonstrating that physicians who do inpatient care and deliver babies actually have a 30% lower risk of burnout. So you're hitting on two of the quadruple aim goals of lowering costs and improving joy of practice. And then continuity reduces the risks of costs and hospitalizations both by 13% if you can get to a high level of continuity. So the things we need those primary care docs to do that they can do right now in small practices in particular actually help the health system. The American Board of Family Medicine surveys all graduating residents as they're coming out. It's really a cross-sectional census. They have to answer these questions in order to sit for their boards. And what we learned is almost a quarter of them want to deliver babies. They were trained to do it and they feel competent and want to do it. Over half want to see their patients in the hospital, and over half want to take care of women when they're pregnant, even if they don't ultimately deliver them. And then when we do the same questionnaire later of physicians in actual practice, we find that less than 8% are delivering babies now, and that's going down. Less than 10% are doing prenatal care, and only about a third are able to see their patients in the hospital. And the message that we had in JAMA 2 years ago about this was that we're preparing a workforce for a model practice they can't find. And we've started to ask them about that specifically. And what we're finding is they're coming out of training, about 90% go directly into an employed position. And 40% of those folks tell us they could not find a broad scope job. They couldn't find one that would allow them to do what they trained to do. Now I want to switch really quickly to this, something we call imprinting. So in the literature, this is talked about with parents imprinting on their children about behaviors that they learned just by association and watching their parents' behavior. This actually happens in medical school and residency training too. And we studied this. We asked the question, can we identify the cost behaviors of an institution and see if their trainees going out into practice continue to operate that way? And the answer is yes. So we studied general internal medicine and family medicine trainees and looked at the hospital referral region in which they trained to see if that pattern of cost behaviors was carried over. And what we found is that physicians who train in low-cost areas became low-cost physicians. That's the column over on the left. And those who train in high-cost hospital referral regions became high-cost physicians. And if you put a low-cost trained physician into a high-cost area, the difference between their behaviors and their peers right next door to them was about $1,000 per year per Medicare beneficiary. And when we got the areas down even smaller to hospital service areas, so you're looking at single training institutions, the difference is almost $2,000. And the first one we published in JAMA, the second in Annals of Family Medicine. And the striking thing is that this behavior pattern lasts for up to 15 years. So I can be working right next to another physician who trained in a different cost basis, and we will practice differently for up to 15 years before we start to look like each other. So it is a long impact. So my question is, why not harness this? If we know we can imprint certain behaviors, and I'll tell you in our second paper we showed we do not imprint quality behaviors. So the thing we try and teach, we don't actually imprint. The thing that is done culturally and sociologically, we do imprint very strongly. But why can't we harness this and continue to train a physician workforce that does exactly what we need them to do in terms of what a reformed health system needs? But the second problem is that we have to give them a place to do that. And so that's the real opportunity. I think we are training a lot of physicians who are prepared to work in a reformed health system. And the challenge next is finding them jobs that will let them do it. Thank you.
Great, thank you. Thank you. And I'm going to ask a quick follow-up question. Bob, you mentioned the quadruple aim. And for those who maybe haven't, can you just explain that a little bit more? What is the quadruple aim?
Sure. So it grew out of the triple aim, which was lower costs, better care, and can anybody tell me the third one? Hope? More satisfaction, but mostly for patients. So the quadruple aim really then builds on, well, what about the providers? And that became kind of joy of practice, which Chris Sinski, who's at AMA, has really championed. It's, can we do all the other things and make it a better experience for the providers? And so when I brought up the quadruple aim, we can demonstrate that we're touching on at least two of those in high-functioning primary care. And the rest we have to study further.
Great, thank you. And maybe we'll get to some of those questions around the physicians and workforce experience of practice and burnout versus joy of practice, which seems like a great goal. Before we turn to Cheryl Phillips, I'm going to apologize for a brief technical message. If some of you are trying to get on Wi-Fi, I think the papers on your tables are incorrect. It's resolution singular, so just in time for your New Year's resolution. Maybe. Thank you, Cheryl.
Great. And there we go. Thank you all for being here. I'm going to shift directions just a little bit. So just a context background about me. I'm a geriatric physician. Geriatrics sort of balances between the primary care specialty world, but as a past president of the American Geriatric Society, AGS is very involved in workforce, including the Geriatric Workforce Policy Center, and focus on home and community-based care. When we talk about what is needed in the environment of home and community, physicians are critically important. We probably need to train over 1,000 geriatricians a year to catch up by 2030, and we train about 240 a year. So we've got a gap, but it's not a physician issue alone. The success of home and community-based care is that wonderful, powerful intersection of the entire team. And I know we say that kind of like jargon, like, oh yeah, it's team-based care, but that's what the richness of home and community-based services. And we have a challenge with workforce. So I'm going to talk a little bit about direct care workforce. Direct care workers, also known as personal care workers, and sometimes misassigned as unskilled, unlicensed, non-professional, which are all the wrong terms, because the direct care workforce is phenomenally important and increasingly so. And so we're going to talk about some of the challenges. I'll start with the problems, but then I want to get into what are some of the exciting solutions and how we can better use. Every geriatrician has to have the demographic slide. That's required, otherwise they take away our board certification. So this just shows what all of you know is that the senior population is growing, and we are here. This is also, and I want to thank Leading Age for some of these slides. Susan Hildebrand will make a more formal connection later, but Leading Age has been working on workforce and has provided some of these slides. But this is some of the workforce needs, particularly in areas of growth, and you will notice that the #1 area of new jobs projected are personal care aides or the personal care workers. The growing demand in the U.S., this is the percentage of increase between 2010 and 2030, and it's estimated that we need over 1 million personal care aides by 2030. And we're going to talk a little bit about why this matters. So the shift from, and I hate using the F word, facilities, but the moving away from congregate settings like nursing homes, where people want to manage their lives, age in place, as we say, in the community. We have an incredibly rich, ethnically diverse, both population of older Americans, but also a population of workforce. We also have an increasingly demanding, and I say that with a positive D, not a negative, of older Americans who now have greater expectations of what their services are, and as well as their complexity of care needs. And we need lots of policy solutions, and that's why we're here, and we could spend an entire time talking about that. I want to call out the Leading Age Center for Workforce Solutions, because there are solutions to some of these challenges. But let's talk about what the power of these home and community-based models can be. And first of all, I'm just going to frame it with what are special needs plans. Special needs plans, for those of you who aren't familiar, are a specialized form of Medicare and Medicaid managed care, but they target high-risk, high-need populations. So dually eligible, those who are dually eligible for Medicare and Medicaid, those who have serious life-threatening chronic conditions, or those who are at an institutional or a nursing home level of care. So these are the three type of special needs plans, and they represent right now about almost 2.5 million beneficiaries enrolled. One of the special needs plans providers is called South Country in Minnesota. This is just a little bit about their geography. And they have focused on taking very high-risk, high-complex needs individuals, particularly those with complex medical needs and behavioral health needs. Talk about a challenge. This is their enrollment, and we're going to look at a particular group of an age band, 50 to 59 years. What they do is they look at the integration of home and community-based services, and this is kind of the, so when you think about a high-risk population, this definition would be they're low income, have multiple comorbid conditions, and have psychosocial or behavioral health challenges as well. What this program does is integrate home and community-based workers, both care coordinators, community workers, which is kind of a whole area of workforce that we haven't tapped into. Community workers can be social workers, they can be public health workers, they can also be non-clinical community workers that align services. And this health plan works with a coordination of the primary care team, these community-based workers, and directly working with the individuals, and not just helping them with medication management and things like that, but truly coordinating their life aspects. You know, we can talk a lot about medical costs, but if you can't get transportation, or you can't afford your meds, or you don't even have a place to live, all of those other things about controlling your diabetes become way secondary in your priorities. So this is some of the demographics. These are the examples of how the model links to community workers and who these community workers are. So in this model, they use social workers, public health nurses, registered nurses, and they align with nurse practitioners and physicians. They also work closely with the veteran services, and they work a lot with the broader integration of community services within the counties that they serve. They focus specifically on needs, but not just healthcare needs, because they know that when they have the infrastructure, they know that these workers need more frequent, high-intensity visits, and yet they have found that when they do these high-intensity, person-centered visits, oftentimes coordinated through direct care workers, the overall medical care costs for the health plan go down. So when we talk about a partnership for primary care and the workforce needs, let's think a little bit bigger. That can be, we have health plans that are working with direct care workers that are intaking information via tablet to triage centers in acute care settings to decide on post-operative people who needs higher level of follow-up. We have service coordinators in low-income housing that are working directly with the primary care teams, physicians, nurses, and social workers. And we talked about the community health worker models that are tying in and coordinating services for very vulnerable high-risk populations. That, to me, is the power of what we can do with community health teams. And the challenge is we have to have the home and community-based workforce to meet that need. Thank you.
Great, thanks, Cheryl. So I'm going to take a little different perspective. So this is a great panel because you're hearing from a lot of different vantage points here. I've got to start off by saying I do like the Yogi Berra quote here, which is, I never like to make predictions, especially about the future. So what I'm going to do is I'm going to bring to you some perspectives from folks who are leading some of these successful new care models and new payment models that are out there. So just very quickly to level set what Premier does for those who don't understand, who know who we are. We work with a very large footprint in the healthcare system. And the wonderful thing is that we've got a small group of our members who want to always be ahead of everybody else. And so we help them succeed in that by using data, by building collaboratives where we actually get them working together and sharing best practices in a more effective fashion. And then we bring that back to policymakers through the policymaking process. And we we've been organizing for the last 20 years these collaboratives on hospital performance improvement, bundled payment, and ACOs as we think about the evolution that's going on in healthcare from a payment standpoint, moving from fee-for-service to new care models and risk. The exciting thing is that these organizations, these collaboratives, the collaboratives that we do have consistently performed significantly better than everybody else in the healthcare system. So our ACO collaborative actually has performed 2 to 3 times better in terms of shared savings than all the other ACOs in the country consistently since 2012. We have about between 6 and 10% of the ACOs in the country in our collaborative. So we've been able to differentiate and do very, very well in those. Our bundle payment collaborative is actually performing 35% better than all the other bundle payment organizations that are out there. This is a simplified way of what we try to do with our members. It's about value-based care redesign, and specifically these are the components of that which match up with the different payment models that are out there. So I'm going to just skip over this quickly. So some overarching data that's out there. I think everyone is aware that healthcare, because of all the points that have been made about the aging of the population and so forth, as much as there's a lot of pressure to bring down healthcare spending overall, and I think we're seeing some very positive trends in that, I think the labor force is liable to be one of the big growth areas overall. This is the quadruple aim that was referenced earlier. This is an area I just share this because I want to focus on what we're seeing specifically happening right now with our members who are leading this change and being successful at it. One of the areas of focus, a theme that we hear from almost all of our members, is it's really about this idea of addressing physician, not entirely, obviously, it's the triple aim, but then it's this fourth component to that, which is physician satisfaction. There's physician burnout. It's a major concern. You're not going to be successful in this care transition if you don't have individuals delivering the care who are satisfied and who are feeling good about their jobs. They will not be as successful. So this is a very important theme that's out there. So these are just some of the general messages. We held a roundtable discussion recently with a number of our primary care, our ACO leaders, and one of the themes that came through loud and clear was the pairing of advanced practice providers or advanced practice clinicians. It's interesting, one of the things that I was thinking about on all the other presentations is just how different terminology gets used to describe different kind of positions that exist. But what's very clear is that there's a significant growth in the use of advanced practice clinicians assisting the primary care physician and the other providers, but particularly the primary care side is what I want to focus on. So because making predictions is risky, I didn't want to go there. So what I did is I did a quick pulse survey of our ACO leaders to look at what are they seeing right now. These are the organizations that are out there, very large ACOs, undertaking these changes right now, these care delivery models. And these changes are, yes, it's Medicare shared savings, but it's also looking well past that. They're doing this with with commercial payers as well. So we looked at at 3 areas. One is the inpatient side, and what do they see going on? I think you all can see these relatively reasonably, but basically on the physician side, what we are seeing is, and what our members are planning for, is that most all of the physician positions are stable. There's no real change that they're seeing, with the exception of cancer, cardiovascular, general surgeons, geriatrics, and hospitalists. And those are the growth areas that they're anticipating right now. And then in the advanced practice providers on the inpatient side, this is all inpatient, care navigators, social work, and community liaisons were the areas that were growing the most rapidly. So I think the community liaisons relate most to what Cheryl was talking about a little bit ago. The other point that has been raised that we are seeing a lot of demand in is around analytics. This is much more focused, obviously, on the clinical side, but our members are investing substantially in clinical informaticists and other analysts to look at the data and understand the data. And this is measurement from a clinical quality vantage point as well as a cost vantage point. So lots of focus in that area right now. And it's really shifting from an implementation of EHRs to much more using the data and understanding the data overall. On the ambulatory side, this gives you a sense there's really no stability, it's all growth. So unlike the inpatient side where you're seeing maybe keeping things the same with the specialists, with the exception of those categories I mentioned, on the ambulatory side, everything is pretty much growing in terms of what is anticipated for the next 3 to 5 years, with the real biggest focus growth areas in behavioral health and primary care. So not really shocking there, but you do get a sense of the relative magnitude. I would add, too, that we've actually, if there's anybody in the press who wants the more updated slides, I've got more of these responses in, so I can provide you even more updated, but it does not change the overall direction of these slides. So this gives you a sense across the care navigators, transition care nurses, disease management, social workers, behavioral health, community health workers, sort of where the focus and growth areas are. Again, all of them are growing. It's just it's a degree, it's a level of growth. And then the last area is the post-acute care side that we inquired about. And this is looking at SNFists, which is sort of a new term that's being used by our members. These are folks who are actually working hand in glove with the skilled nursing facilities, home care, rehab, community liaison, social work, and behavioral health workers. And everything, again, here is growing with the exception of rehab, which is actually stable or declining, I would say, or and then the other areas are growing with the greatest growth areas in social work and behavioral health. So that's sort of a on-the-ground look at what's happening right now from some health systems that are at the leading edge of change and successfully working in these areas of change. Sarah.
Great. Well, thank you. Thanks, Blair. And I think you've heard from 4 very different vantage points, but I think all pointing to, perhaps some need to look at, how are we looking at the workforce going forward to create that high performance system. So I want to ask, one kind of kickoff question, and then I want to invite the audience. And you guys are on it, man. You guys already have your questions, but if you think of questions, please write them on a green card, and Suvri will pick up your card and bring it up to me. If you want to ask a question at the mic, there are a couple of mics there. But I want to ask, and Blair, your presentation was interesting in that you identified a number of providers that I think were new to me. I haven't heard, we haven't heard of SNFists, or, you mentioned like several different kinds of nurses. I want to ask, kind of a general question. I mean, do you see, for anyone on the panel, do you see kind of a growth in these different kinds of providers growing, and sort of for what purpose? And then, is there anyone we're missing in the lineup? So maybe feel free to answer.
Well, I'll jump in. I had to go.
Yeah.
Because I had a SNFist contract in 1992, being a long-term care physician, but they thought I was an allergist, and they had written it as SNIFF. So anyways, the one workforce area that, because what I was focused on were these models, but we absolutely have to acknowledge, and that is the informal, the family caregiver. That is the largest workforce in this country, and it's the one that is not recognized, not adequately prepared for. We assume that because you have a family member somewhere in town that they will default and be your caregivers. And the
the workforce dollars, the prep that we just assume is out there, to me, that's a huge gap in workforce, and there's an area of policy, and I know we have several representatives here. I see Catherine Kelly hiding around in the back and not, focusing on how do we address policy for the informal workforce, that being family caregivers, and family is defined by whom I choose to have as my personal caregiver. So that's a workforce challenge.
And Liz Hall earlier mentioned kind of social isolation, and I wonder if some of the care transition nurses, are they kind of intended to help bridge some of these gaps?
Well, I think without question. I think the thing that's interesting is, so are there new positions? First off, we have changed. I mean, things in healthcare have changed rapidly. I mean, you made this comment at the beginning, Sarah. It's really pretty remarkable how quickly we've seen changes among our members in terms of how they're approaching the healthcare delivery process, in terms of getting community workers actually involved in a way that they've never even hired them in the past. And now we actually have some of our health systems who are starting to think about social determinants on health. And we did a study recently on this, which was fascinating to see that some of our members are beginning to really think about how do they coordinate care across all of these social agencies that exist, so senior centers and so forth. And they're not coordinated in the communities right now, and investment goes all over the place. So they're actually investing in individuals to work on those in a way that they've never done before. So there are a lot of new positions. That's why I think it's interesting when I look at these different terms that we've been using on this panel. It's all over the place in a lot of ways. So in some ways, standardizing some of this terminology would probably give us a much clearer picture about what's going on in the workforce. I think this your use of the term, direct care workers is really an important part of it as well.
So Blair, I really appreciate the responses you got from the ACOs, and I'm going to focus on the outpatient setting for just a minute. We certainly need a lot more of those community care workers, social workers, care coordinators, community-based nurses, behavioral health specialists. I would submit that we not only need them, but we need them to develop relationships with our community-based providers too. My for example is that we had an insurance provider that put care coordinators into our practice. They were there 2 days a week, tried to work remotely by phone. They would tag off on patients rather than develop relationships with them, and didn't really spend a lot of time with us. And what we kept hearing is, oh, I can't take care of that patient. They are way too complex. And we said, well, that's exactly why you're here. And so we had to, the problem was we never developed the relationships between the care coordinators and the patients, or the care coordinators and the physicians, to try and help us all deal with really complex patients. And my other, for example, is I think the Vermont Blueprint for Health has done this really well under their Medicare waiver. So you have small practices that can't afford to bring those people in, so they created a community resource. So they embedded these social workers and behavioral health folks and community care teams in the community, and then had them develop the relationships with the practices and the patients, so that no one had to own that infrastructure, but they all owned it in a relationship way. And that's, I think, really executed nicely. So it is about more of those workers, but the relationships have to set up, or they just can't execute on what they need to do.
If I could just add one thing. So for many of these health occupations, we do need more. The question is, are we training enough to meet that more, or are we training too many or too few? And in the case of registered nurses, we do need a lot more nurses, but we're probably overtraining. In the case of licensed practical nurses, we do need more, but we're probably not training as much right now. In the case of some of the direct care workforce, it's really hard to actually model the future supply, because you can train many of these occupations relatively quickly to ramp up, but it becomes more along the lines of, are you willing to pay for them? And so if you're willing to pay for them, you will have the supply, but if you're not willing to pay for those services, then there won't be enough.
And there was actually a question on the green card about to your point about nurses, and the questioner cites that there's some research that shows a lack of nurses in the long-term care space, and where, you were talking about kind of overtraining nurses. So the question was, are you looking at, you mentioned a couple different types of nurses just now, but and we know there are many different kind of degrees and things like that in the nursing profession, but could you maybe speak a little bit more to that? And are there, nurses in different settings where maybe there just isn't the right kind of distribution or that kind of thing?
Sure. So on the demand side, the demand for nurses is growing more rapidly in some settings versus others. And we've seen, for example, in the hospital inpatient setting, that will still continue to be the dominant employer of registered nurses, but it's not growing perhaps as fast as other settings. But also, in the case of long-term care, it becomes not so much that we don't have enough nurses, it's just that in that setting, we're not paying nurses well enough to attract them into that setting and retain them, because a nurse might come out of school and perhaps is having a little difficulty finding a job. They say they go into long-term care, and then a position opens up that pays more, and they leave.
I was on the National Academy of Medicine study, the look back at the Robert Wood Johnson focus on nursing. And what was stunning to me in that is that less than 5% of RNs are in outpatient setting, and probably less than half of them in primary care, which we desperately need nurses, especially high-skilled nurses in primary care right now. So it is a payment issue, and it's a priority issue. How do we actually get a higher trained workforce, nursing and otherwise, into a setting where we can help stave off the higher cost later and keep them healthier and living longer? And it's really hard to pull them in with what we can pay them now.
And I would agree, the reference was to salary, which is a huge issue, but there's more than that why people don't stay in long-term care. It is not recognized as a value career. Whether you are a nurse, a social worker, a therapist, a direct care worker, a physician, a nurse practitioner, as soon as you say, I work in nursing homes, the look is like, well, gee, I thought you were smart. Couldn't you get a job somewhere else? We don't value it as a healthcare system. Payment hasn't valued it. Payers haven't valued it. Hospitals haven't valued it. Healthcare training hasn't valued it. I dare say that few healthcare professionals, regardless of your discipline, are ever even put a foot in a nursing home. So there is a whole lot more. And then you throw on crappy pay. And gee, I wonder why, it's like, how else was the play, Mrs. Lincoln? There's a lot of forces, and yet this is where our real growth of workforce, not just nursing homes, but in the broader sense of long-term care supports and services. We have to professionalize it. We have to give adequate resource and training. Salary is a big piece of it, but there's more to the professionalism and recognition of value. Salary is part of it.
And Blair, you mentioned, you had a whole slide just on the post-acute space, and recognizing that long-term care goes beyond the post-acute space, but do you think that with the focus on higher value care, on delivery system reform, particularly within the Medicare and Medicaid program, is there a growing recognition of the need to address some of the issues that we're talking about in terms of that connection between health and long-term care? And we've talked a lot about the dual eligibles, for example, and sort of their high cost, high need population. Is there going to be a movement and more of a push towards better integration or coordination or policy changes around that area?
That's what when I was, all of those positions, I would say, in the post-acute care side of that slide, those are all focused on really coordinating better the care delivery process. The thing that we've seen with our membership is the leaders is that there's just huge variation. I'm not saying anything people don't realize. Huge variation in the way post-acute care is delivered across the country. And we actually have a data system that we use. It has over 1 million claims records in it from the Medicare ACOs that looks at all of these different ACOs that we have. We have about 50 ACOs in this claims database. And we look at how they array against one another in terms of the way care is being delivered and where the costs are and so forth. So we can look at inpatient, ED stays, or ED visits, every component, post-acute care, home health, SNF, all the sides of post-acute care as well as ambulatory care costs. And then we compare our members to one another in all those different areas. The area that is for a lot of so every community is going to be different, no surprise there, but we see consistently huge variation on the post-acute care side, and it impacts so many parts of the healthcare system. So it impacts the readmissions to the hospitals. So the SNFist positions are largely around managing, trying to reduce the readmissions to the hospitals is really what the focus is there, as well as ED visits. So it's really coordinating the care and making sure that we don't have additional costs that occur as a result of somebody who's in a skilled nursing facility. Oftentimes, one of the things that we've seen with our members is that on Mondays, there's a huge number of patients who end up in the hospital because over the weekend, and I know this is somewhat anecdotal, but it's actually happened in a lot of communities where the skilled nursing facility isn't doing rehab, it may not be staffed as much, and so we have a lot more patients end up in the ED or back in the hospital for some reason. So that's just an illustration of what we are seeing with in these ACOs. So the post-acute care area is where, in many cases, the ACO is actually hiring the person to do this additional work. In other cases, they're setting up what we call high-value networks with post-acute care providers. So they're working more closely with certain post-acute care providers who are investing in those additional resources. So that's where we get that information from. And in some cases, they actually own those post-acute care resources, and so they're directly involved in the employment process through that. I hope does that make sense?
I think so. Does anyone want to weigh in? I see Amy, did you have a question?
Yeah, I did. I'm Amy York, and I'm with the Elder Care Workforce Alliance. We're a coalition of 31 different organizations collaborating to really make sure there is an adequate workforce to provide quality care for older adults. And there's been some mention of training, but not specific to older adults. And I'm curious, how much you all have invested in training and retraining, really, because a lot of the workforce has never been trained in geriatrics or in the care of older adults. And there are not enough geriatricians and will never be enough geriatricians out there to provide this care or geriatrically trained professionals. So what are the types of things you all are looking at in terms of training the entire workforce to care for this aging population?
Yeah, maybe I can make a comment about that because last time I had a conference call with a group of geriatricians out in Florida. The comment went something like this: Tim, you stabbed us in the back here, because a lot of times things are misunderstood in terms of the demand for healthcare providers. When we look at older adults, the large majority of care provided to them is provided by general internists, not geriatricians. And so when we look at the demand for geriatricians over time, the question becomes not so much about the aging of the workforce, which is important, the aging of the population, which is important. It becomes more, how much of that care will be provided by a geriatrician versus a general internist? Because what happens sometimes, as you might imagine, is a person starts with a general internist when they're younger, and they stay with them, and they stay with them, and they stay with them, and they tend not to go to see the geriatrician until they have to actually physically move to a setting where they're no longer with their general internists. And that makes it a little bit difficult to model future demand for them. And so what we tend to do is just look at the demand for the older population in general, and then let the specialties kind of duke it out among themselves, who's actually going to provide that care.
Amy, so family medicine sponsors about 1/3 of the geriatrics trainings programs, and internal medicine 2/3. With reduction in OB care and pediatric care, we've seen in family medicine the average age of our patients shift a great deal. And in rural communities, it's almost all family physicians and nurse practitioners and PAs taking care of that population. What I've noticed in working in Northern Virginia with a fairly affluent population is the greatest shortage we have are of geriatric psychiatrists. Yeah. It is incredibly hard to get a patient into a geriatric psychiatrist, and even in an affluent area. So we have shortages in providers of all kinds in the geriatric realm, and for a lot of the reasons that Cheryl mentioned. I'm sorry? Well, I thought I heard someone say something. But it is an acute need.
Well, as a fellowship-trained geriatrician, I sort of feel obligated to jump into some of the conversation. We know that, it's more than a physician issue, so I want to make sure, as I'm talking about geriatrics, a solution is not just physicians. But there is a reason, I think the geriatric shortage is very real. And part of I'm not denigrating my internal medicine colleagues. I'm a family medicine trained and then fellowship trained geriatrician. Geriatricians and geriatric health professionals know things and do things differently than general primary care providers do. Doesn't mean that they're better or worse. It's just they understand falls, they understand polypharmacy, they understand medication management in the frail elder, they better understand early signs of cognition, they understand the intersection of function and medical issues in a way that very often a disease-focused approach. So getting back to your point, Amy, I think the answer is you're right. When we train 243 geriatricians a year, we're not going to create the gap, but we can help with the geriatric health profession training across the board so that all nurses, all RNs should have time on aging services, that all primary care physicians should not just have the token 6 hours of elder care, but should actually have experience of older person care in varieties of settings, including home-based care, assisted living, nursing homes, post-acute. The same with social workers, the same with physical therapists. There are also some very novel and very productive programs for family caregiver training. So some of the states, I'll even use Arkansas, has a wonderful model of training direct care workers and family caregivers in the unique aspects of care for individuals with dementing illnesses. And sometimes the related, we call them behaviors. Frankly, it happens to be the way people with dementia often need to express themselves, but teaching family caregivers how to do that well. So there are training models out there, and they aren't free. And anytime you have an add-on, there's a cost to someone. Medicaid at the state level is rarely picking up these kinds of costs, except in a few novel kinds of programs. Post-acute and long-term care providers are struggling to keep up with the training demands, but without reimbursement for the workforce to do that. So we have the needs, we have some solutions, we have some great models. We need to pull it together in new ways of thinking of how do we train all health care and direct care workers in the care of particularly frail and vulnerable older adults.
Thanks. And I'm going to ask
I just had one follow-up. We actually have been talking to folks about the Geriatric Workforce Enhancement Program, and I just wanted to mention that because it's the only federal program that does training in geriatrics. So
Thank you.
I don't know if all of you are familiar with it, but it's a really important program, and we actually have some representatives from programs if you're interested in learning more about it.
So I have a kind of a related question that came from one of the cards, and then I'm going to go to a different set of questions that that came in, kind of switching topics. So, and this is a little bit perhaps something Cheryl might be able to answer, but a lot of the in terms of the growth of different healthcare jobs, a lot of the growth seemed to be kind of in the perhaps lower paid professions, and you mentioned direct care, and so the question was, are there training initiatives, or how much is there like a focus on a career ladder, and how much is it a career ladder issue versus just a pay issue from the get-go? If you could comment on that.
And I'll
very brief because I'm sure there's others that want to as well, but that's part of where the solution lies. There are some states that are doing remarkably innovative things in career ladder. It is more than salary. Salary is important, but it's also a recognition of professionalism. It's a recognition of skill sets. It's a recognition of I have some place to move to in a career path. The state of Minnesota has done some exceptional things in identifying both career paths, training gaps, peer training. I'm a firm believer in one of the ways that we elevate the professionalism is when we have, to use the jargon, train the trainer. How do we do peer training models? And then where do we look for workforce investment in particular shortage areas? So again, Minnesota has done some exceptional things. I would also encourage you go to the Leading Age website, as I'm seeing Susan there. So www.leadingage.org, and then look for workforce. And there's a number of model solutions on how we can approach some of these very things.
Thank you. So we had a number of questions come in around payment, and since you mentioned it's not just pay, it's a workforce ladder issue, and we've also talked about satisfaction. There were several questions kind of under the umbrella of how does payment of clinicians affect some of the statistics that were mentioned in the presentations. One person mentioned the MACRA, the Quality Payment Program, which we had a lengthy briefing on last week, but talking about some of M.S.P.H's recommendations to kind of, as this person says, split the physician fee payment red tape. And use sort of some different methods of payment. So there's that piece of a question, and then another person asks about differences in pay, which is an issue we've been talking about for a long time around kind of pay for procedure-based versus non-procedure-based, and kind of so there's kind of a lot of different things wrapped up in those questions. But I guess I would ask the panel to maybe comment on. Does payment affect these issues around, and I would say payment not just in terms of levels, but in terms of how we pay, like in the sense of payment reform, how does that affect how the workforce is able to be prepared to deliver this high performance health system?
Well, it's an important question. The differential, particularly between the cognitive and interventional specialties, is not just a physician issue, it's across the board. So we did a study a few years ago that showed that the differential between primary care or cognitive specialists and surgeons and interventionalists has grown so large that it reduces the likelihood that a student entering medical school will go into one of those lower paid specialties by over half. So it's like losing half of your training pipeline to the cognitive specialties. And it just continues to grow. So there is a big issue there. And it's also affecting our nurse practitioner and our PA pipelines. Only about a third of PAs now are in primary care and less than half of NPs, and we need them desperately. But they can be paid more. And then there's the issue that Cheryl brings up, that payment often gets intractably intertwined with perception and value. It's not just about payment, it's that you're smarter than that, or your career ladder ends, and so we have this compounding effect where we can't keep people in the specialties and in the arenas where we need them, particularly to take care of an aging population. And the value-based payment systems, where you're offered a bonus of 4 to 9%, it's not going to really put a huge dent in it, and when there's a risk of a loss of equal amounts, that's what's driving small practice people to be employed. And then you have an added problem there that the value-based payment process, quality payment program, is not really about quality because it's budget neutral. It's about differentiating winners from losers. And so there have to be equal number of losers to pay the winners a differential bonus payment. And so we're starting to see quality measures top out, like this quality, and it speaks to these cognitive specialists that, that measure is no longer important. I have to chase this one now. And so it creates a burnout cycle for those folks that they're constantly chasing something new and shiny in order to stay afloat, not to really get a substantial bonus. So we have a number of problems, even around the new payment system.
So I guess I want to ask, and Tim, some of your modeling around population health and what the potential demand would be. I was a little disappointed because I was hoping if I just like eat my broccoli and play tennis for that we won't need so many doctors. But if I'm understanding your statistics correctly, the demand for specialists is still very much going to be there. Even if we achieve some modest population health improvements over time, which doesn't, I don't know how optimistic we are about that. And I think if I'm interpreting, Blair, what you said about the staffing needs for inpatient professions, there's still going to definitely be a demand and a need for certain specialists. And I think you mentioned cancer and cardiovascular in particular. So am I getting that right? And what can you say about that?
Well, it always gets tricky when you talk about dying here, but the ideal way to die is you live a long, healthy life, and then when you die quickly at an old age, right? And what you can see, for example, like if people are smokers, they might die younger, and they might die relatively quickly, from cancer or something.
Good
and,
know.
and if you, yeah, that's all very bad. But if you can get them to stop smoking, instead of dying at age 65 quickly, what they might do is die at age 75 or 80 from another disease. And so what we see is this trade-off between, well, I'm not going to die of cancer, I'm going to die of heart disease or diabetes or, Alzheimer's or something. And so you see this shifting among different health occupations, but in general, it doesn't really reduce the demand overall. It just extends it out to a person's later years in life.
We had one kind of standalone question about telemedicine, which was what role will the increased use of telemedicine play in addressing projected shortages? So if you could speak to that and the impact of telemedicine on shortages and perhaps any other aspect of workforce that you'd like to.
Well, for telemedicine, we've tried to model the workforce implications of telemedicine, and it's actually very difficult because of just lack of data. The type of literature that's published tends to be, it works, people like it, they're happy with it, but it tends not to say the physician is going to spend so much more time or less time per patient, and so it's really hard to quantify what the impact will be. But one has to believe, at least on the access side, it opens up lots of opportunities to people that geographically live in areas where they have limited access, but it's just hard to quantify the impact on the workforce.
Yeah. I think one workforce, we made reference to behavioral and mental health issues, the ability to leverage behavioral health and mental health services through telehealth, particularly in congregate settings, home and community-based settings, adult day centers, nursing homes, things like that is very powerful. There are a number of challenges. With the Chronic Care Act that the Senate passed with unanimous consent, there's some real opportunities for telehealth, and I think for targeted service areas, telehealth has a huge impact on expanding our workforce challenge gaps, and we'll use behavioral and mental health as a good example of that.
So let me just add one thing here. So a lot of this conversation has been around the challenge from a payment vantage point with the way the system is paid today versus the labor requirements of the future. So it's challenging because everybody's being paid a certain way today, and it's based on the services that are provided. And of course, we're looking at a very different way of delivering care overall. So, when you think about the organizations who are making the greatest change, that's who I'm really speaking to, is these are the organizations, they may be aligned with commercial payers, plus they're in Medicare, next gen kinds of models, or M.S.P.H, or one of those more advanced models. They're really trying to change the way the care is being delivered overall. So hospital in the home, and that uses a lot of telehealth. So, telehealth comes in a lot of different varieties, and our members are trying to test a lot of different things that they can, strategies to use less expensive, less intensive sites of care to deliver high-quality care and better outcomes. So, I was mentioning it earlier about the change in the workforce in the skilled nursing facility and the variation in care across the post-acute care side. What is a clear trend in the leaders is a movement to more home health, and that's including using telehealth as one of the enabling features of that. Trying to limit the length of stay in some, skilled nursing facilities in particular, because there's huge variation. That's where we see enormous variation. So limit the length of stay, or make sure that the length of stay is appropriate, and then shift to more home health settings. And then again, use technology where possible.
Thank you. Joyce?
Yeah, Joyce Frieden from M.S.P.H today. I wanted to ask a little bit about the other end of the pipeline, like, if we're changing the types of people that we need in the healthcare workforce, are medical schools or nursing schools going to be able to react and, train people in the specialties that are needed, or encourage more people to go into primary care, and kind of what are people seeing on the other end?
Well, one of the challenges, let me start with nursing. One of the challenges with nursing is that there's no one coordinating how many are being trained, right? Individual universities and programs say we want to build or expand our nursing program, and they do so. And sometimes what happens is it takes a while. You get nurses coming out into the workforce, they're having trouble finding a job, and it takes time for it to filter back into people that maybe were considering nurses as a career, that maybe I'm a little late jumping into the game because they've already ramped up the number being trained. So there's that issue. We did a study for the veterinarians a few years back, and their concern was that they were just overtraining veterinarians. And the challenge for the association was, will we get into legal problems if we tell the universities to cut back on how many we're training? And so the associations are very conscious of giving that kind of direction about restraining the number of people being trained. So in general, though, I think many of the professional associations, they're aware of needs among their members and trying to put out information that we need to be training more, need to be training fewer, given that there are still a lot of unknowns, and you don't want to overtrain or undertrain because there are costs to society. If you overtrain, that means people will not have as productive of a career as they could have found if they had found a job, or career where there's more demand for their services. And of course, if we undertrain, then it puts patients at risk.
And Tim, if I could ask you to clarify, like in contrast to nursing, where you said there's kind of no one overseeing, or, in medicine, you have a little different system.
Well, I think with medicine, and with the whole GME program, you have caps, and how much money are we going to spend in graduate medical education? So that does put some restrictions on how many you train.
But if I can just add, but it doesn't restrict, so if I'm a medical student and I'm making my choice on economics, if I'm the first one to the Easter egg hunt and I get into radiology or dermatology and I win, and then the ones that didn't, so we have a bizarre skewing. But I want to get back, Joyce, the biggest predictor of healthcare professionals who will work in aging services is if they have a mentor that teaches them. So if you have an engaged nurse who loves elder care services and inspires his or her nursing students to have practical experience that talks about the value of it. If you're a physician in training and you work with a primary care physician that loves their practice, and particularly if they have a geriatric practice, those are the things that predict better than. We have to integrate real training into all of our nursing, social work, therapy, physician programs, but we also need to embed passionate mentors.
And how do you do that?
You make it of value to the mentors to teach. And right now, let's be honest, medicine, and I say medicine not just as doctors, and the big M, is a business, and form follows finance. And if A, we don't value aging services, 2, we don't particularly value teaching all that much, and we really don't value teaching about aging services, then you're not going to have a lot of invested mentors to support mentees. So part of it is recognition, and then it all goes back to the entire cycle. Do we value workers who create their career paths to serve older Americans, older adults? And to the extent that we don't, then we don't raise up all of those workers who choose to make that their career path. So part of it is how we value, and I think that demand and need and some of the new models, which is why I wanted to talk about the community-based models, as we raise the professionalism, that's going to help.
Thank you. Okay, we have a question at the mic, and then we had a question from Twitter, and then I think we're going to wrap it up pretty quickly. So go ahead.
The mic comes before Twitter. I'm Robin Golden. I'm from Rush University Medical Center in Chicago, and we have a couple social work-based models that we're wrapping around primary care to create that community-based primary care concept that one of you spoke about, as well as wrapping around the hospital. We've been replicating these models nationally. As part of our sustainability plan, where the new CPT codes in the last couple of years related to transitional care and care coordination, the CCM, TCM codes, just in the last week, we found out that unless you're co-located in the physician's practice, you really can't be part of those reimbursements. So, you know, as we're talking about team, as we're talking about bridging the hospital to the community, how can we relook at these codes that are so physician-centric? It's just, I don't know if anyone has a response, but a reaction.
Well, Robin, it's a huge problem, and I'm hoping that some of the models that Blair mentioned specifically, where you're getting paid to take care of a population, will shift the reimbursement to social workers in the community in particular, where it's not about a transaction.
Right. It's about a relationship.
It's about a relationship, and it's about helping that person solve their housing stability, which is what keeps them out of the emergency room, keeps them going to substance abuse treatment, and keeps them from showing up in the hospital 2 years from now with infections. The social workers are so important on the front line, and to make it a transactional fee-for-service type of service is really hard to sustain.
Thank you.
The only thing I wanted to say is, we haven't talked at all about behavioral health. And, that came out in our survey loud and clear, and I just want to underscore that is another, when we looked at the drivers of cost with our members, this patients who have behavioral health challenges, I guess we mentioned it in terms of the geriatric psychologists, but psychiatrists and psychologists, but it is a major issue from a cost vantage point and from a care delivery vantage point that we're increasing. Our members are very, very focused on this. The ones who are, again, leading edge, really trying to change care delivery in their communities.
And that was actually why I targeted the South Country model, because they focus on dually eligible individuals with behavioral health problems. So it's that comorbid, if you will, medical problems and behavioral mental health problems, and how do you create a team-based infrastructure that works within the unique model of primary care, but the impact to be able to reduce costs, but not just reduce costs, improve people's lives is profound. So yes, it's that marriage.
Some of the stories around this that we have from our members it's really it's amazing when you hear them about what they're doing with patients who've shown up at the ED 200 plus times over the course of a year, and they have behavioral health problems, and where they go and they address the root problem and remedy the ED admits and so forth. It's amazing.
Great. Well, thank you. So I do want to get in. This is a little, maybe more of a statement from Twitter, but it gets a little bit to that point about, valuing and professionalism, which is kind of why not apply the Zappos model to healthcare? So the model of good customer service, and if you treat clinicians with respect and value and support them, then good healthcare for patients will follow. Is the statement here? And I guess maybe the question I would ask the panel is, distilling everything you all have said, which is a lot. What are some of the key elements that you think are critical to good models of care that support? Maybe I could say like a healthy workforce, and therefore good patient care. And what are some of the critical elements in your view? And maybe since we only have a few minutes left, I'll ask you, is there something that you wish policymakers knew that would help support that?
Well, I think it's teams and relationships. So you're increasingly asking a primary care and geriatric workforce to take care of more and more complex problems, to keep people out of the emergency room and out of hospitals. And what we found is as you build a team around those people to offload the work of the physicians so they can do what they do very well, but also have relationships with the people they work with. So the behavioral health is embedded in primary care, that social workers are embedded in primary care. It not only offloads the work, it enhances the work they can do. And that what Sinski's work has shown and Tom Bodenheimer's work is that it's incredibly rewarding because you recognize you're really making a difference. And particularly around the social determinants of health and behavioral health issues where we've been very unempowered, we suddenly have resources. That's really important to improving the joy of practice. And the joy of practice is important for all the reasons you mentioned, and to Cheryl's point about having mentors who are passionate and engaged about what they do, so the next generation sees that that's a viable option for them.
Thanks.
We often use the phrase having a workforce that is adequately prepared and resourced. And really in those two words is kind of the summation. So the workforce being that very broad, not just physicians or nurses, but the broad, and adequately prepared. Have they had the training, the resources that they need? Do they have the connection to things like behavioral health support? And are they adequately resourced not only with their own salary, but with career ladders, with mentors, with peer training relationships, with access to continuous learning, and to professional recognition, and that's from the direct care workers on up through. So I think being resourced and adequately prepared, and there are policy solutions in each one of those. There's workforce training grants. There's ways to look at a variety of policy enhancements at both the state and the federal level to make sure we have an adequately resourced and prepared workforce.
So just to build on that, Sarah, if I may, the interesting thing, we've all been hearing about HCAP surveys and patient satisfaction surveys for a number of years. What has been interesting with our members is how much we've seen a growth in the use of the physician satisfaction surveys. So they're equally weighted, equally important, and a lot of focus on that in terms of who's being successful in achieving more satisfied physicians. So it's another element to this discussion we're having, but I totally agree with what was said earlier about the support and we've all heard the right care by the right person, right time, all that kind of language. But from a policy vantage point, I just underscore that what I said earlier, we really need to get out of this very micromanaging healthcare system into something which is a more flexible system that allows the innovation that we need in healthcare. And I think we all realize that. It's just the transition is extraordinarily difficult and it's taking a long time. But the organizations that are really innovating are the ones who are the most liberated from a payment vantage point. They are either have their own health plans, so they're able to innovate with their own health plans, or they've taken risk almost entirely with a very large portion of their patient population. So it's not just a fraction of it, it's a much larger commercial, Medicare, their own employees, kind of a population that they're looking at.
Thank you.
I'd just echo what Blair said. As we look into the future, there is an enormous amount of work that needs to be done to take care of the future healthcare needs of an aging and growing population. And by getting away from the micromanaging, as Blair mentioned, by breaking down some of these artificial barriers that we created due to how we reimburse care, scope of practice, legal constraints, that they're all put in there for a purpose, but they are hindering becoming more efficient as a healthcare system.
Thank you very much. Well, we are out of time, so I want to ask you to join me in thanking our panel. Thank you. And thank you all for being here for what is also the very last Alliance briefing of 2017. So please fill out your blue evaluations. You don't get off the hook with that, but thank you all for being here. And please have a wonderful holiday, and we'll see you in the new year. Thanks.